Hi, this is Elliot Fishman, and welcome to our CT is Us Facebook Live. Today is Thursday. I think I got to check my calendar here. I know we're in July 22. It's amazing how quickly July has come and gone. Somewhat amazing. I'm getting all these calls. Look at this thing. People are sending me messages. Um, anyway, um, so I hope everyone's doing well. I know it's temperature is hot everywhere. I hope everyone's doing good. The air conditioning in my house on the second floor broke, though it's new, so I'm sweating it out. But anyway, hope everyone's doing well. We have been posting. I don't know if I know that we're at near records. We're nearly 2 million people a week are visiting us on our Facebook page. We also are seeing more than ever people on our YouTube channel and Instagram, as well as our apps. We've upgraded, thanks to Sarah, all of our apps, updated and upgraded our apps. We updated the eye lectures just the other day, and last week we did the eye pearls, the eye quiz, and I'm leaving something else out. We have this new incredible version of the lumbar spine that we're doing final testing on. Oh, we updated the chest app with cinematic rendering for anatomy. And all the team, thanks to everyone who votes for us on and Mini. We've won. We are always, we take the and Mini best app to heart. We try really hard all the time. So if you vote for us, it wouldn't hurt you any. So anyway, that's just a joke. Anyway, so that becomes very, very important. All of us are back. You see, John Biacchino is one of our senior techs in CT, and the hospital, him and I were scanning a patient this morning, so yeah, it was good to see John as well. I think everybody is coming back in force. Diagnostic radiology at Hopkins, CT, MR, ultrasound, fluoro, biopsy, plain films. We are here, and we're trying to do as well as we can, so people are great. We just got great news on some of our work on AI, our app, an AI. Basically, we basically are got refunded by the Lustgarten Foundation. Okay, amazing. So just our 5th year, so we're really excited about that. We're doing some other work I can't tell you about right now that I'm in the process of getting straightened out. Also on AI, I think will just be world changing. So we're super, super excited about that. We're also a new year. I think all of you, those of academics especially, know we have new fellows, new residents. The residents don't affect us too much in the beginning of the year, surely, but the fellows really, we got great new fellows, so we're excited about that. We're also in the process of recruiting. If you're looking for a job, if you want to do mainly clinical, if you want to do clinical and research, you want to do clinical and research and teaching, you want to do clinical and teaching. If you want to do a great job, we are recruiting. You can give me a call. You can email me. So we are aggressively looking for really good people. Our volumes are over pre-COVID, so we're really busy. And we're looking for people who are looking for great opportunities for advancement. So we're looking for that. So hopefully that indeed will be great. So if anyone's interested, you can email me or call me. What else? Other things that we are looking at, we're looking at just basically trying to figure out some of the workflow in terms of things like cinematic rendering. We're looking at doing cinematic rendering with holograms. We're doing that already. Looking at doing multimodality, PET, CT, and holograms. So we're really trying to push the envelope. I think we are excited about doing great things. And I think it's a wonderful opportunity. Our biggest challenge, I feel, at Hopkins really is just manpower. It's just really, really hard. Under the obnoxious thing, which I mean, obnoxious is on my part, but from Manverda to people in Nepal listening to our lectures. So it's great. I also, some of you know that I posted a Facebook Live spontaneously on Tuesday this week when Jeff Bezos and his rocket went to the moon. I won't get into the shape of the rocket. I kind of noticed that, but didn't really think about that. That it looked like Austin Powers. I'm sure you've read about that this week. But I mean, I went on and on about the fact that the Bezos rocket went up and went higher than the stuff from Virgin and Branson. But you know, it came down with a parachute and it landed clunk in the middle of Texas. And it didn't land in the middle of Dallas in the Super Bowl. It would have landed at Dallas Stadium where the Cowboys played. That would have been super cool. But it landed in some dusty field. And I gotta say, that did not look super cool. That Branson thing, it was a super cool rocket taking off, shooting the thing up, and then you landed it really super cool. It was very, very elegant. But Jeff Bezos told me that he had previously offered me that I could fly for free on his spacecraft. He rescinded the offer. And also they're going to refuse probably to deliver any Amazon packages to my house, which in a pandemic is really bad. But even in a non-pandemic, I get a lot of cool things from Amazon. And I'm a shareholder, so Jeff, you know, be cool. Jeff Bezos, amazing. You know, we always said that Amazon, someone told me to buy Amazon when the stock was like 5 or 10 or something like that, and didn't make any sense to me. But Bezos, as Warren Buffett would say, is one of the visionaries of our time or any time, and he just amazing. I did get a note from my son. I don't know if he's listening, but this is one annoying things. You know, for music, I love the Eagles and I love Eric Clapton. I went to London to see Eric Clapton in Royal Albert Hall with my kids a couple years ago. But now Eric Clapton refuses to play at venues requiring proof of vaccination for audience. Eric, baby, what are you thinking? Give it a rest. Play guitar. Don't be getting political. Why when you're in your 70s are you going to say stupid things like that? You know? And I hate to say it, Madison Square Garden, you're not going to be playing in Madison Square Garden because they're not going to let anybody in. You're not going to be playing at the Capitol Center or Verizon Center in Washington because you don't got a vaccine. You ain't coming in. I don't know where you're going to go. Maybe there's some places in Florida, they seem not to be as strict perhaps, or in Alabama or Mississippi or maybe Nevada. But you ain't coming to the East Coast, to Boston or New York or Washington or Philly or anywhere like that, or any of the California arenas. You know, Eric, man, give me a call and I could speak to you and tell you. As my sons say, you don't want to be increasing, this is sad, you don't want to be increasing the number of tears in heaven. I'm not sure I would go to a concert now with or without a mask. Surely without a mask, I surely would not go. But maybe I'd go outside Central Park, but I don't think I'd go to a concert right now. Hopefully that will get better, and hopefully I won't be such a wuss, because I want to see Clapton, I wanted to see the Eagles, I want to see a bunch of different things. But right now, I think the best you could do, and I'm not going, is the concert in New York in Central Park, the free concert with Paul Simon, I think with Bruce Springsteen. So I think it's going to be great. So anyway, okay. So let's see. I'm supposed to speak about the spleens. Before I run out of time, let's talk about the spleen. Now, at the end of the day, in an asymptomatic patient, that means no fever, no weight loss, no left upper quadrant pain. Most of the splenic lesions you see are going to be benign. Often it's cysts, often it's hemangiomas, sometimes it's hamartomas. Hemangiomas occasionally look like hemangiomas in the liver with peripheral enhancement, though most of them don't have that. Hamartomas, when they're 3 or 4 centimeters, usually are exophytic in parts and cause a bulge in the capsule of the spleen that can be helpful. Seen better early, and on late phase imaging become isodense. So most of the time, and there aren't that many tricks, it's not like you do dual phase or you do dual energy or you do MR. Most splenic lesions are indeed going to be incidental. Findings are going to be benign. Now, if you have a low density lesion, so let's take size, okay? What about a big spleen? What about a big spleen that's homogeneous? So you can have a big spleen for a number of things. Portal hypertension, give you a big spleen. You can have leukemia, lymphoma, mononucleosis, so benign and malignant can give you a big spleen. Often when you have a big spleen and you have a salt and pepper appearance of enhancement, particularly a venous phase, that means your patient has leukemia or some other infiltrating process. We look at the presence of calcification, a splenic mass with calcification, usually linear, circular, usually it's an old trauma, but it can be TB or histoplasmosis. That's something to think about. We also need to be willing to think about when it's low density infiltrating. Lymphoma, abscess, infarct. Most infarcts tend to be wedge-shaped and peripheral. Infarcts are often associated with endocarditis, post-op patients, a number of different things. But they do have a certain appearance, and you got some history. Abscesses and lymphoma can look the same, particularly if you only see a low-density lesion in the spleen. Obviously, when you look at the spleen, you look at other organs. Multiple lesions in the spleen and liver, patients relatively asymptomatic, lesions 1 to 3 cm. You got to be thinking about sarcoidosis, one of the great mimickers. Multiple tiny lesions in the spleen, maybe liver, maybe kidney, the patient's immunosuppressed. You're thinking candidiasis or aspergillosis. But the history there is the key thing. You have a mass that's growing into the spleen, well, then you're looking typically at pancreatic cancer, though you can look at lymphoma, you can look at gastric cancer, but that's easy because there's something else to be seen. I'm really talking about these isolated splenic lesions. 98% of the time or so, they're going to be benign, leave alone, not to worry about, need no other studies. What else can you do if you're not sure? Sometimes ultrasound helps, MR helps. Surely if you're worrying about extra splenic involvement and you don't see much, a PET CT would be helpful in terms of things like lymphoma. But again, with lymphoma of the spleen, sometimes you have primary splenic lymphoma where there's no adenopathy present. That's pretty rare. But in primary splenic lymphoma, the spleen is usually large and there's a mass present and it's irregular or infiltrating. So it's not going to be just your basic incidental findings. So I really don't have a problem there. My problem might be lymphoma versus an abscess. Metastases can involve the spleen, but then they're not well defined. Then also typically you'll have other areas, things that go to the spleen. One of the most common to give you multiple splenic lesions might be something like melanoma. That's a really good one. You can also see mets from renal cell, which can be vascular. Obviously, lymphoma gives multiple lesions. Colon occasionally, lung cancer occasionally. But multiple lesions, melanoma, sarcoidosis. Again, a sarcoid, liver, spleen. Melanoma can be liver, spleen, mesentery, bowel, chest. So also when you think about sarcoid, you want to look at the chest because often the patient has adenopathy that looks very much like adenopathy that you'll see in the chest. So that's something also to consider as a realistic possibility. Other things in terms of the spleen, as I mentioned, infarcts, solitary or multiple. Often the patient can be febrile, left upper quadrant pain. Patient can have history of surgery, endocarditis, vasculitis, could be a whole range of possibilities and a whole bunch of things you should be thinking about. And that becomes very, very important as well. Now, as I mentioned with spleen, and this is something we always talk about, of course, is the spleen is not in isolation. I mentioned this a few moments ago. Look at the liver, look at the kidneys, look at the mesentery, look at the paraortic regions, look at the chest. Often the presence or absence of disease in these other locations will help you determine how significant the finding you have is. Now, people do ask, what about biopsies? People have done biopsy of the spleen. We do them very, very infrequently, but you can do it. That's always a possibility. So it's something to think about, though I have to admit the number of splenic lesions we do are very small. Now, in terms of the history, patients with splenic lesions that become worrisome, be it infection or tumor, patients with HIV, patients with AIDS, patients immunosuppressed. All of those things, obviously immunosuppressed patients, you can have lymphoma, leukemia, but you also can have abscesses or infarcts. So it is somewhat challenging. Now let's see, I'm looking here at my questions. Besides people being very complimentary and saying hi, anyone have any questions about the spleen? Liliana doesn't have any questions, but Liliana says hi. Liliana's out in Palo Alto. Hey, Liliana. And Liliana also gave us this really good song this morning from, I think, a Netflix movie that you probably saw about 7:30 in the morning. A question, how do you differentiate lymphoproliferative disorders from hemangiomas? That's a good question. As I mentioned, sometimes hemangiomas have peripheral puddling, but sometimes they're just low density lesions which really don't have any enhancement. I think what helps me most of the time, hemangiomas, typically the spleen is not enlarged. Lymphoproliferative disorders, it's almost always enlarged. One exception might be multiple splenic hemangiomas in Klippel-Trenaunay-Weber. Then often they have linear calcifications, but they're much sharper defined. When you have lymphoproliferative disorders, the spleen is often enlarged, and then often it's a salt and pepper appearance, and the low density lesions are there, and they're multiple, but their borders are not as sharp. I think that is indeed very helpful. How sharp the borders are. Hemangiomas, whether they enhance or not, have pretty sharp borders. Cysts have pretty sharp borders. Density is 0. With lymphoproliferative disease, they're typically low density, but they're 30 Hounsfield units. The edges aren't sharp, and things are not as well defined. So I think that would be very helpful as well. Okay, what else? No, but I think I'll just be fair to Manverdi that sometimes I think it's really hard because the history is vague symptoms, some weight loss, maybe some low-grade fevers. And sometimes, you're saying, am I overcalling this being tumor? Could this be just hemangioma? So every once in a while, I do think it's somewhat tricky. Most of the time, I just really don't think that I have a significant problem making the right diagnosis. So that's kind of a little bit about the spleen. I am working for the next couple weeks. I think we're going to have, or at least maybe next week it's scheduled if we get it set right. We're going to have some really good talks about rhesus reads, how to do rhesus reads. I know people have asked about that. We all do lots of oncology work. How do you do rhesus reads? What is a rhesus reads for some of you who don't know too much about it? Very important. And how do you do the measuring so that you could do it in a very reproducible way? Remember, oncology depends on us to do follow-up studies and say better or worse. Is it 20%? What's going on? Oh, last question. Borderline splenomegaly, asymptomatic patient. If I see no focal lesions and the spleen's a touch big, I'll just say the spleen's a touch big and leave it at that. Remember, people say 13 cm is the maximum size of the spleen. The spleen varies. It's more like volume. So if it's borderline big, I'll mention it, but I'm not going to say advise anything at that point. I think depending on the clinical scenario, people might do different things. Younger patients, spleen looks a little bit big. Maybe you do a mono test. Usually the spleens are really big in mono. It's things like that. So I think you have to use a little bit of the clinical judgment at that point. So with that, I'll stop there. I'll let everybody go back to lunch or go back to work or go back to whatever you're doing. I hope everybody has a great day, and we'll see you online. Okay? Catch you later. Bye, guys.